Thank you. Thank you, everyone. Last year, I'm a poor surgeon, a physician being invited in a den of surgeons. Dr. Qureshi said the attention span of a surgeon for a physician is about 5 minutes, and he gave me 15 minutes. I think this year, to test the hypothesis further, has given me 30 minutes. So thank you very much for inviting me. Let's start. So conflict of interest, as you can see, these are the companies I've taken sponsorship from. So I have no conflict of interest. I've taken money from everyone. Okay, so let's start with the first case. So this is a 26-year-old lady who presented with thyrotoxicosis. It was a second episode, difficult to control. She had some problems with the anti-thyroid drugs and eventually decided to go for surgery. The endocrinologist prepared her. The TSH was still 0.0. Thyroxine was just within control at 19. The range is 10 to 20. Very good surgery, uneventful, not a drop of blood was shed. And next day, you come on the ward round, and the professor who's done the surgery says, fine, surgery is done, tells the registrar, now start this patient on thyroxine. What do you do? So here's your question. Do you give 75 micrograms of thyroxine, 100 micrograms, ask the endocrinologist, or give it according to weight? How many for one? For two? So most would do that. Three? Only one. And give according to weight? Right. Okay. That's where we can discuss a little bit further. Okay. So to give any drug, it's useful to know a few things: how it works, what dose to use, what's available in the market, the size of the tablet. If it's an elderly patient, doesn't apply here. The pharmacokinetics. What are the contraindications, side effects, precautions? And it's worth knowing about the cost of the drugs, etc. And I'll tell you why it matters in this situation. So we have to give thyroxine, but let's just spend a little time going into the history. How did it all start? So the ancient Greek knew about the thyroid gland. But they thought the job of the thyroid gland was to lubricate the larynx for a while. Although the Chinese were using seaweed to treat goiter for about 2,000 years. And in fact, right up till the last century, there was some view that women had bigger goiters because they spoke too much. And so here's the Russian 1820 saying that because of the vexatious nature, the women have bigger thyroid glands. And then they came up with this idea that the thyroid gland was a safety valve. It had very big vascular supply. So if all the blood rushed up to your head, you need the thyroid gland to act as a safety valve. So it's surprising not much was known about it. And it was right in 1836 that Thomas King, who was at Guy's Hospital, and he was mainly a pathologist, who said it secretes some sort of a peculiar fluid, which has got something to do. And of course, in 1877, one of the other physicians from St. Thomas's, from not far away from Guy's, said that it creates a situation by lack of the thyroid, which is a myxedema. But the real action was taking place in Switzerland, where Emil Kocher, who was a Swiss surgeon, was performing thyroidectomies. Everybody in Switzerland had goiter because of the lack of iodine, and many of them had tracheal compression. And between them, these two performed nearly 4,000 thyroidectomies, and they were so good that they had reached a complication rate of less than 1%. That's in 1912. Uh, sorry. So, but they never followed up this patient. And then somebody had a bright idea to go and see it and find out what happened to the patient. And they found the results were unfavorable. That is to say that most of them developed problems because there was no thyroxine. And it was really in 1888 that George Murray, who was a 25-year-old junior doctor in Newcastle, decided to give extracts of the thyroid gland to some patients. Remember, he was 25 years old. So by today's standard, he would be the equivalent of an FI2 or a CMT. So he decided to make this extract and give it to the patients to see what happened. The first patient did very well. Of course, he was poo-pooed. And they said, this is stupid. Next, you'll be saying that if you want to treat spinal cord injuries, you're going to make a concoction of spinal. And he was not allowed, he was not given the facilities. He persevered. The second patient he gave too much, had a heart attack and died, which wasn't very helpful. They didn't have appraisals in those days, otherwise he would have been caught. But then he started doing that, and that caught on. And it was only up around 1927 that thyroxine tablets were made. Until then, you had to give this horrible-looking concoction to the patient, which you had to inject. I'm not going to go into the basics now. So now, you don't have to do that. You have to give a tablet. So how much do you give? So to find out how much you will give and when you will give, that's the next question. What is the half-life of thyroxine? How long does thyroxine last once you take it? How many for 6 hours? 24 hours? 7 days? Oh, the majority. According to weight? So the right answer is 7 days. So when you give thyroxine, it lasts for 7 days. So the half-life of thyroxine is 6 to 7 days. It's slightly higher when the metabolism is slow with hypothyroidism, and slightly faster if you are hypothyroid. So just think about it. You have operated on this person, this lady, who was just within control. So this lady still had thyroxine circulating in her blood from yesterday. And if you had given the full dose of thyroxine, she would have had double the dose in a post-operative phase. So therefore, it's useful to know what is the half-life of any medication. Personally, in that lady, I would have waited 48 hours, that's what I advise, and then start the thyroxine. If you're in a situation where you have removed a multinodular goiter and the person was completely euthyroid, maybe after 24 hours you can start. Okay. Next question, how much to give? So there are a variety of ways of finding out how much to give, and different people use different things. And this is actually a calculator, dose calculator. It's very complicated. And some people, especially in the States, use this. You can give a bigger dose, a total replacement, or you can start with a smaller dose and build up. The evidence is that it makes no difference. So this is one of the studies which looked at giving a smaller dose and then building up or using a full dose. The results were not very different. So the usual requirement is 1.6 microgram per kilogram body weight in most patients. However, in the elderly and in the very young, you just have to be careful and probably start at a lower dose. So most of you were right. In that lady, one would start with 100 microgram, but probably wait 48 hours before starting. What are the preparations available? These were the preparations available previously. It used to come in 25 and 50s and 75. But as time has gone on, a lot more of these preparations that are available now, and you can get them in all sorts of doses, such as 12.5, 75, etc. It is very interesting that the smaller doses like 12.5, 37.5, 75 are 2 to 3 times more expensive than the previous doses of 25, 50, and 100. And in many CCGs and many GPs will not prescribe them. They will only give the standard dose. That's a problem we face in our area. Of course, if you are working in the continent or in the America, you get all these sorts of tablets available, which are very handy because patient comes to you and says, well, I'm taking my lilac tablets. So you know the person is on 175, says I'm taking yellow tablets, they are on 100. But this is not available in UK. What precautions would you take when you're giving medication to somebody? So you're giving somebody thyroxine tablets, and you may need to give them some advice and warn them about the precautions. So thyroxine is mainly absorbed from the jejunum in the ileum, and 80% of it is absorbed in most people, but there's a large variation in the clearance rates in different people. A lot of medication and things interfere with thyroxine. So that includes iron supplements, calcium, and many of them will be requiring calcium also. Antacids particularly. Thyroxine needs an acidic medium to be absorbed. So if you give them milk or antacid, it won't absorb properly. Okay? I'm going to show you about 7 or 8 slides showing you some studies. Don't spend too much time looking at it. It's just to show you that people have actually done work on this. Okay? The main drugs you need to be aware of is iron, calcium, and antacids. So here's a study looking at 14 patients. They were given thyroxine for a period of time, and then the same patients were given iron tablets together with the thyroxine, and the TSH went up from 1.6 to 5.4. And 9 of the patients actually had signs and symptoms. Calcium, there are lots of studies. Singh and Singh, probably a husband-wife team from LA, have looked at that and again showed that calcium interferes, and giving calcium together with thyroxine will increase the TSH and decrease the thyroxine levels. Another study by the same group. Soy, a lot of ladies in this age group, in the perimenopausal age group that we see who have thyroid problems, also take soy. So if you're going to give them thyroxine, you need to advise them not to take it with soy. So this is the list of drugs that, as you can see, interfere. Sometimes you use cholestyramine to stabilize people before thyroidectomy. So again, you need to be careful about that. And here's the bad news. Coffee, unfortunately, interferes with the absorption of thyroxine. So we need to warn them not to take it with coffee. Okay. So this is another study. Somebody's actually given thyroxine with and without coffee and shown the differences. So when you're giving thyroxine, you need to tell the patient how to take it. You need to advise them to take it first thing in the morning. I personally tell them, keep them next to your bedside, take them as soon as you wake up, and then go and have your shower and brush your teeth, etc. And then there'll be half an hour before breakfast. Otherwise, the thyroxine may not work. When to give it? So this study looked at giving it before breakfast, after breakfast, and at night. Other similar studies have looked at this. It does not matter when you give it. The important thing is to give it on an empty stomach, and then give them time, maybe half an hour at least. Recommended is 1 hour before they eat. What cautions and warnings do you have to give them? Uh, People who have cardiac problem, you need to be careful about giving the thyroxine. You may have to give a smaller dose and work up uh, because you can precipitate cardiac problems, quite obviously. Oral contraceptive pill, estrogen increases the thyroxine metabolism. So if you're going to give somebody thyroxine, you need to warn them that if they take HRT or if they take the contraceptive pill, they may have to adjust the dose. And most important, especially this was a young lady, you have to warn them that if they become pregnant, they need to seek advice. So during pregnancy, the normal gland increases in size by about 30% and produces about 30% extra thyroxine for a variety of reasons, including the increase of thyroid-binding globulin, the dilutional effect, the placenta converts it into reverse T3, etc., etc. So, and that thyroxine in the first trimester is very important. So I'm going to show you quickly 3 slides which show the effect of low thyroxine during pregnancy. This is an American study which looked at the IQ of people whose TSH, mother's TSH was slightly high, and it showed a 7-point difference in IQ at the age of 8 to 12. Again, study from Holland by Pops, which again shows similarly a difference in the milestones for children, and a study from China similarly. So it is important because if you are giving them thyroxine and they're not going to see anybody else, you need to warn them that if you become pregnant or if you're trying for pregnancy, you may need to increase the dose and make sure you seek advice if you become pregnant. So in summary, thyroxine can be given at 1.6 microgram per kilogram body weight. Always give it on an empty stomach. It can be given any time of the day, but has to be on an empty stomach. Avoid all the other drugs that have been mentioned. You have to give them advice regarding contraception and pregnancy, because if they're not going to see anybody else, then the onus is on you. So this has been the journey of the thyroid gland. So as you can see, the Chinese were using it in the 17th century, and then the extract came up in the 1890s. In 1927, it was first synthesized by Harrison here, and then we had synthetic thyroxine, etc. And then now it's one of the most commonly used drugs. But there are still some controversies which are going on, which includes the use of T4 and T3 levels and how to interpret the T3 levels, which often you are presented with. So some of the controversies that are present in the field of thyroid replacement is the use of T3 and the use of animal thyroxine, which is known as NDT, natural desiccated thyroxine, how to replace in young people, and the role of vitamin D in surgery. So I know this is probably not of interest to you, surgeon, but one of the big controversies in the world of thyroid is the use of combination T4, T3. In the 90s, some people from Eastern Europe started using a combination of T4, T3 and showed symptomatic improvement. This was not substantiated in subsequent studies, etc. But there's a whole load of people who say that they feel significantly better on a combination of T4, T3. And that wasn't too bad until a few years ago. Then one clever pharmacist called Mr. Patel, who lives in Essex, decided to buy up the competition and jacked up the price of T3 from £8 for 28 tablets to £350 for 28 tablets. He earned 267 million, as reported by the Daily Mail. So if it's a Daily Mail, it must be right. But they also had pictures of his Bentley and his Rolls Royce, etc. And this has been debated. This has been debated in the House of Commons. Sir Vince Cable raised it, debated in the House of Lords, where Lord Hunt raised this question. There was a big half an hour or an hour debate, and basically the government said it is not to up, it is for competition to do that, etc. So this has become a big issue. And of course, the animal thyroxine came up because Hillary Clinton, when the health records were released, was using animal thyroxine. It has looked very unfavorably in Britain, but very much used in America. I won't even go on how to replace in young people and how to get the normal ranges, etc. For them. That is a full debate. But I'm going to show you 3 slides to the role of vitamin D. It is now being recognized that if you replenish people by vitamin D preoperatively, then the chances of getting postoperative hypocalcemia is lower. So this is the first study, which clearly, I'm actually just going to show you these 3 studies, and I've got the conclusion in the 4th slides, okay? So another study showing exactly the same thing, perioperative calcium replacement, and this is what the conclusion are. All the studies show that if you give sufficient calcium in people who are deficient in calcium and replenish them, and we like to call a level greater than 75 as replenished, then the chances of postoperative hypocalcemia is significantly lower. And so much so that 2 years ago, the American Thyroid Association in its guidelines actually recommended, and if you look at it, if surgery is calcium and 25 hydroxyvitamin D should be assessed preoperatively and replete if necessary. So they actually recommend prophylactic vitamin D and calcium and getting vitamin D right before surgery. Okay, just a couple of slides before I end on postoperative hypocalcemia. I'm not going to go too much into that. The incidence of postoperative hypocalcemia, as you can see here, is up here, is fairly high, particularly if you're doing block dissection. So what do you give? Do you give calcium? Do you give vitamin D, or do you give vitamin D and calcium both? Okay. So there are various ways of doing this. You do nothing and see if the calcium drops, and then you treat it, or you start on 1 alpha, which is activated vitamin D, or you can give a combination in 1 alpha and calcium. This is a complicated chart by the British Endocrine Society. I'm sure you don't want me to go into it, but what the suggestion now is, and most surgeons, I'd be guided by you, Dr. Balasubramanian, is that many surgeons now routinely give activated, which is 1 alpha vitamin D and calcium for 48 hours after surgery. These are just some thoughts. I'll end there.